Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey, cardio nerds. This is Rick Ferraro, cardio nerd and cardiology fellow at Johns Hopkins University. I'm really excited to be joined today by a number of tremendous trainees at West Virginia University. We're going to hear an awesome case from them within our CardioNerds Case Report series. I'm here joined today by the incredible Dan Ambinder. How are you, sir?
I am so great, Rick. It is an honor to be here.
Fantastic. All right. So we are joined today by some fantastic trainees at West Virginia University Medical Center, and we're going to learn a lot about an awesome case today. Emily, would you mind introducing yourself briefly?
I'm Emily Hendricks. I was born and raised in West Virginia, and I went to medical school in Huntington, West Virginia at Marshall University, and I'm currently a second-year internal medicine resident at West Virginia University. Outside of work, I enjoy weightlifting and hiking.
Hello, everyone. My name is Lei Pan. I'm a second-year cardiology fellow at West Virginia University. I went to medical school in Shanghai, China, and did my internal medicine training in New York at Jacobi Medical Center. Before residency, I did 1 year of research in hematology. Even though I followed my passion into cardiology, I still get excited when I take care of patients with hematological disorders. After cardiology fellowship, I plan to continue with interventional cardiology training. Outside of work, I enjoy skiing and hiking.
My name is Bei Jiang, and I am currently a third-year fellow in hematology and oncology at West Virginia University. I'm originally from China and received my PhD in pathology from the University of Nebraska Medical Center and the City of Hope Cancer Center in California. Although I initially thought I could become a pathologist, I soon realized that I was a little too talkative for that, and I was really fascinated by oncology. After completing my internal medicine residency at Lincoln Hospital in Bronx, New York, I came to West Virginia for my fellowship. I'm delighted to join my cardiology colleague today to discuss this interesting case, and I had a lot of fun to work with our internal medicine resident, Emily, who is more interested in cardiology than hematology for now.
Oh, that's amazing. Emily, Lee, and Bei, wow, it is so great to meet you all. And as our listeners are already here, we have quite a diverse group in terms of fields of expertise and medical training. This is going to be an absolute delight to hear about your case and learn about your patient. But before we do, please take us to one of your favorite places in Morgantown, West Virginia for a treat before we get into some serious cardiology/hematology/internal medicine.
So my favorite place in West Virginia is Dolly Sods Wilderness area. It's a great place for hiking, and I really enjoy going backpacking there.
The approval from the locals can speak volumes. My favorite is the Seneca Rocks. I went there last fall season to watch the foliage. It was gorgeous.
I agree with them. My favorite places are basically all the mountains in West Virginia. As we mentioned earlier, we have lots of friends work in different departments. Sometimes we just go hiking or skiing different mountains, and then we would rent a cabin, eat hot pot for 4 hours, and take a nap and talk about all the interesting cases that we saw in the hospital. It's pretty fun.
That's fantastic. So it sounds like we're going to maybe talk about a case while we're out hiking or maybe sharing a meal in the woods. So this sounds like a great one. So why don't we get started with our case?
That sounds good. We have a 38-year-old man who presented with chest pain radiating to the left side across the precordium, lasting for about 30 minutes at a time. It was non-exertional, non-positional, and non-pleuritic. It was triggered by emotional stress and relieved by relaxation. It occurred a few times, about once every other day. He had never had pain like this before. He denied any dyspnea or leg swelling. The patient smoked a half pack per day for 15 years and denied alcohol or illicit drug use. His past medical history was significant for hypertension, sleep apnea, and peripheral neuropathy. He had no family history of premature coronary artery disease, and he denied any recent travel. Vitals revealed a blood pressure of 143/85, heart rate of 93, respiratory rate 19, temperature of 99.1, and his oxygen saturation was 100% on room air. On physical exam, the patient was not in acute distress. His cardiac exam was normal without any murmur, rub, or gallops. He did not have any JVD or lower extremity edema. His extremities were warm and well perfused. He did not have lymphadenopathy, and he had symmetric and equal pulses throughout.
Let's summarize. Our patient presented with the chest pain. He appeared stable based on the vitals. The chest pain was atypical, no association with exertion. He had intermediate cardiovascular risk factors such as 7-pack year of smoking and hypertension, even though he was a young man. Emily, what would your differentials be?
My top differentials were acute coronary syndrome, pulmonary embolism, pericarditis, aortic dissection, and pneumonia.
This is concerning, right? And for the cardiology fellows here and really trainees across departments, this is something that we see and immediately we got to start thinking about what's going on here. I really like, Emily, the differential that you put together. What we have here is a 38-year-old man, right? So relatively young. You had mentioned, Lee, that it was kind of a atypical presentation. I think in the new chest pain guidelines, they would recommend that we characterize it by cardiac, non-cardiac, or possibly cardiac. Still relatively young person, has some risk factors, does have a smoking history, and so certainly thinking about cardiac causes. But as you mentioned in your differential, we want to think about non-cardiac causes as well. And so what we have here, it seems like a pretty broad differential that you presented us. Emily, why don't you take us to the EKG and a little bit more data?
The EKG showed sinus tachycardia and T-wave inversion in the anteroseptal and lateral leads. His labs were remarkable for a mild leukocytosis with a white blood cell count of 12.1, a creatinine of 1.36, a high sensitivity troponin of 861, a D-dimer of 703, A1C was 6.2, LDL 107, and HDL 23. The rest of his comprehensive metabolic panel was normal. This is a patient with chest pain, a positive troponin, and an elevated D-dimer. He was found to have a mild acute kidney injury, prediabetes, and dyslipidemia. Chest x-rays showed no acute cardiopulmonary process. Due to an elevated D-dimer, we proceeded with CT-PE, which ruled out PE, aortic dissection, and lung parenchymal disease. The patient was admitted to the cardiology service for NSTEMI. Serial troponin 6 hours later was 968, then 1,457, and then later peaked at 2,074.
Yeah, so I think now we're pretty clearly dealing with a cardiac process, right? In the least, there's some cardiac involvement here, and ruling out PE is helpful for taking that on or off the differential.
The next thing that we did was we got a TTE, which showed a normal ejection fraction of 55% with no wall motion abnormality and an abnormal diastolic function with elevated filling pressure. The patient underwent invasive coronary angiogram, which showed mild coronary artery disease without any culprit lesion to confirm NSTEMI. We did the ischemic workups, which turned out to be negative. What do you think this patient has with this chest pain and positive troponin?
That's an excellent question, Emily. I think this is not an uncommon scenario we encounter on a daily basis. So there are a lot of differentials for elevated troponin in medicine. Demand ischemia usually takes up a big part, but when there's imbalance between oxygen demand and supply from other underlying illness, the myocardium can leak troponin, especially in the area of high sensitivity troponin. However, our patient presented with cardiac chest pain without other active illness. We should take him out of this category of demand ischemia. Next, we need to make sure there's no other pathology on the coronary angiogram was overlooked, such as SCAD, spontaneous coronary artery dissection, and plaque disruption. When clinically suspected, intracoronary imaging such as IVAS or OCT can be utilized to diagnose SCAD, as well as the subtypes of plaque disruption, such as plaque erosion or plaque eruption, by identifying the fibrous cap of atheroma. The MI with non-obstructive coronary arteries was observed 80 years ago. However, the term MINOCA was only recently brought up within the last 20 years. I'd like to go over the 3 criteria when we diagnose MINOCA. First, there's acute myocardial infarction by the 4th universal definition. Second, on the coronary angiogram, there's less than 50% of stenosis. Third, there's no alternative diagnosis. In order to further look for causes of myocardial infarction or injury, Emily, what would you consider as the next step?
The next thing that I would consider is cardiac MRI. Cardiac MRI is helpful in identifying the ischemic or non-ischemic causes. The distribution of late gadolinium enhancement, T1 and T2 mapping can highlight the area of myocardial scarring, necrosis, fibrosis, and edema. The different patterns of the signal distribution can provide a clue to the extent of myocardial involvement in its pathophysiology. However, there is logistical concern with cardiac MRI, and that is that it's costly, and some hospitals don't have cardiac MRI on site or a dedicated MRI for cardiology. So sometimes when obtaining an inpatient cardiac MRI, this can lengthen the length of stay by at least 1 day.
That is very true. The guidelines currently recommend cardiac MRI in all MINOCA patients without obvious underlying causes.
We scheduled the patient for outpatient cardiac MRI and discharged him with aspirin, beta blocker, ACE inhibitor, and a statin. Unfortunately, the patient was lost to follow-up.
So I might just pause there for a second, and I want to compliment you both. That was such an incredible discussion of where we're at in the differential. The way you went through this, I think, is the way that a lot of centers and a lot of groups would have gone through this, right? You get an echo that just doesn't have any discrete wall motion abnormalities, but does have some abnormal diastolic function, right? And you would not expect that in a 38-year-old otherwise. And so it seems like something's going on. With the troponin elevation, you take them to the table of truth, right? You go to coronary angiography, and it shows what you'd expect in a 38-year-old with kind of a mild, moderate smoking history. There's some coronary artery disease, but certainly nothing to explain this really elevated troponin and this presentation that is very concerning for cardiac chest pain. And so now we're in this situation where we need to do a little bit more homework. And so it sounds like he was lost to follow-up, but what happens next?
So 2 months after discharge, he presented again to the emergency room, this time with right arm numbness and confusion, which was concerning for stroke. CT brain showed multiple areas of decreased attenuation in the left parietal and frontal lobe with small area of hemorrhagic conversion, concerning for an embolic source. His brain MRI showed innumerable foci of acute stroke throughout the bilateral frontal, parietal, and occipital lobes and within the cerebellum with petechial hemorrhages, as well as the parenchymal hemorrhage. Of note, the patient's white blood cell count at this time was 11.3, and his serial troponin is 411, 375, and 431. EKG showed a normal sinus rhythm with a right bundle branch block and T-wave inversion on the anterolateral and inferior leads, similar to the previous EKG.
So the patient was recently diagnosed with MINOCA, now presented with stroke, unchanged EKG, and flat troponin. ACS is not really on my top differential anymore. Plus, his recent coronary angiogram 2 months ago showed no obstructive disease. So there are actually 2 top differentials coming to my mind: myocarditis or neurocardiogenic syndrome. So let's talk about neurocardiogenic syndrome first. It is described in patients who had acute stroke, concomitantly found to have myocardial injury by either blood work with elevated troponin or cardiomyopathy on echo. It was observed in more than 50% of the patients with acute stroke. The mechanism of it is not fully understood. It is believed to be the catecholamine surge in the setting of acute stroke, leading to myocardial injury from vasoconstriction and calcium overload, similar to the stress cardiomyopathy. So what does the patient's TTE look like this time?
The TTE was obtained, which showed global hypokinesis of the left ventricle, an akinetic apex, and large LV and RV apical thrombus. The left ventricle ejection fraction was 30 to 35%. This is probably the source of embolic stroke for this patient from his large LV thrombus.
You're absolutely right, Emily. The risk of embolization of LV thrombus can be up to 22%. Isolated LV thrombus is known to occur after anterior MI or in dilated cardiomyopathy. The reduced cardiac contractility results in static blood flow, predisposing patients to thrombogenesis. What really caught my eyes is the biventricular thrombus. It is a fairly rare presentation. There are only case studies available in the literature. The majority of the cases are associated with hypercoagulable disorders, such as protein S, protein C deficiency, as well as other cases such as eosinophilic myocarditis, biventricular stress cardiomyopathy, or methamphetamine use. The pathophysiology of intracardiac thrombus formation follows the rule of virtuous triad. Endocardial injury, hypercoagulability, and stasis increase the risk of thrombogenesis. In our case, the apical obliteration with the biventricular thrombus actually made us wonder, brought our differentials in terms of could it be some atypical diseases, because such a unique finding of biventricular thrombus with apical obliteration after we review the literature, it points to a specific disease, eosinophilic myocarditis. So eosinophilic myocarditis is also known as Laufer syndrome. It was first recognized by Laufer in 1940s. It is different from the Laufer syndrome in the lungs caused by parasites. The pathophysiology for eosinophilic myocarditis involves eosinophils infiltrating the myocardium, causing myocardial necrosis by degranulation. There are 3 stages in the disease. The first is acute phase, eosinophils infiltrating the subendocardium. Patients are usually asymptomatic, but can occasionally present with ACS or tamponade. The second phase is the thrombus formation, during which patients can present with thromboembolic events like stroke. The third phase is subendocardial fibrosis due to persistent inflammation from eosinophils. Patients can present with heart failure symptoms in this stage. Emily, after we looked up this finding with the biventricular thrombus with apical obliteration and think about eosinophilic myocarditis, can we review what actually his eosinophil count is?
Yeah, the initial absolute eosinophil count was 2,230. With the concern for eosinophilic myocarditis, we obtained cardiac MRI, which showed a mildly decreased left ventricle systolic function with an ejection fraction of 43%, hypokinesis of the mid-inferoapical segment and apex, and an increased negative T1 time of 1,095 milliseconds, indicative of myocardial fibrosis. There was no evidence of myocardial edema. There was subendocardial late gadolinium enhancement involving the mid and apical segments of both ventricles and apical thrombus in the left and right ventricles. Findings of complete obliteration of apices with biventricular apical thrombi and subendocardial fibrosis concerning for eosinophilic endocarditis.
Yeah, so this is really interesting, right? And thank you for presenting that to us, Emily. Again, I would point listeners to the webpage for this episode because the MRI findings are pretty striking. And one thing that you mentioned that is even a bit more concerning is that we're already seeing fibrosis and we're not seeing as much edema, right? And so this is, as we've expected in someone who was lost to follow-up, was scheduled for an MRI, comes back with a little bit more of an acute presentation concerning for stroke. It seems like this process has progressed from purely initial injury, edema, to now the later stages. And so what did you do next? And what was the next thought processes of the group?
The MRI is actually really an excellent tool staging the eosinophilic myocarditis and giving us more details to this disease and make us understand better. So I want to try to emphasize on the distribution of the late gadolinium enhancement in the subendocardium. In our case, actually differentiates eosinophilic myocarditis from other etiologies or other types of myocarditis. And also the apical obliteration of both ventricles is quite unique in the eosinophilic myocarditis. And the imaging findings actually can evolve with the clinical stages of eosinophilic myocarditis. Our patient's presentation, like you mentioned, Rick, should be at the second stage because he has thrombus formation in both ventricles and the absence of edema and the presence of subendocardial fibrosis, pointing to a less acute process, suggesting the patient is transitioning to the third phase, fibrotic stage.
With the classic imaging findings, should we proceed with endomyocardial biopsy?
That's a good question. In general, endomyocardial biopsy is recommended in patients with fulminant myocarditis or with high-risk clinical features such as ventricular arrhythmia, acute decompensated heart failure, and cardiogenic shock. For patients with acute myocarditis with a low to intermediate risk, cardiac MRI is recommended. For our patient, it wasn't hard to choose because he has thrombus in both ventricles, high risk of embolization during endomyocardial biopsy if we were to pursue it. He's clinically stable without high-risk clinical features, which makes him an excellent candidate for cardiac MRI.
Now that we have the diagnosis of eosinophilic myocarditis, how should we treat it?
It really comes down to 2 aspects. One is to manage the acute cardiac conditions. The other one is to treat underlying causes. The first-line treatment for eosinophilic myocarditis is corticosteroids. A meta-analysis showed that steroids use is associated with lower mortality rate. There's no clinical trial data available in therapies for eosinophilic myocarditis. The dose and duration of steroids in the report varied in each individual case. For our patient, he also has biventricular thrombus, which needs anticoagulation. Vitamin K antagonist is the standard of care for intracardiac thrombus. It was described in the case report that complete resolution of biventricular thrombus was achieved at an 18-month follow-up with warfarin in eosinophilic myocarditis. There's also emergent data showing non-inferiority of using DOAC for LV thrombus compared to warfarin. When patients are subtherapeutic on warfarin, the risk of stroke increases. Currently, the guidelines recommend DOAC as a reasonable alternative to warfarin LV thrombus. And for the other potential complications, such as heart failure, arrhythmia, pericardial effusion, standard of care is recommended. There's no large data to suggest any other specific approach to eosinophilic myocarditis. Also, in the case report of eosinophilic myocarditis with severe cardiomyopathy due to drug allergy, patient achieved full recovery with GDMT and discontinuation of the offending agent.
We started warfarin with a heparin drip to bridge the therapeutic range. We initiated Solumedrol 500 milligrams for 3 days, followed by a prolonged prednisone taper starting at 60 milligrams daily. This patient presented with significant hypereosinophilia and was diagnosed with eosinophilic myocarditis, which suggested hypereosinophilic syndrome. We contacted our hematology colleagues to assist with further workups and treatment planning. Bei, as a hematology consultant, what's your approach to hypereosinophilia syndrome diagnosis?
First of all, I appreciate the internal medicine team and a cardiology colleague for their prompt action in stabilizing the patient and preserving his vital organs over the weekend. It was a great start to the week, returning from the weekend skiing trip and sipping coffee, and then being presented with an interesting and rare hematology condition. So before we discuss the workup for hypereosinophilic syndrome, let's review its definition. Hypereosinophilia is defined as an absolute eosinophil count, more than 1,500 cells per microliter in the peripheral blood, on 2 examinations separated in time, and or pathology confirmation of the tissue hypereosinophilia. A hypereosinophilic syndrome is defined by the association of hypereosinophilia with the eosinophil-mediated organ damage or dysfunction, provided other potential causes for the damage have been excluded. As a hypereosinophilic syndrome is a clinical diagnosis. Any specialty can diagnose hypereosinophilic syndrome by following criteria. So you don't necessarily need a hematology to help you make the diagnosis. But hypereosinophilic syndrome can be idiopathic or it can be associated with a variety of underlying conditions, including allergic, rheumatologic, infectious, or neoplastic disorder. Oftentimes, hematologists are involved because, of course, we're blood doctors, and we can assist in identifying potential causes, and we can treat if the underlying cause is a hematologic disorder.
Understood. When we diagnosed our patient with hypereosinophilic syndrome with cardiac involvement, we reached out to cardiology to manage the acute organ dysfunction. It's a good idea to consult hematology to help subclassify the hypereosinophilic syndrome, or in other words, to identify a potential cause. What would the workup include?
I just wanted to jump in for 1 second and again, congratulate you guys and stand in awe at the multidisciplinary work that went into this. And you've got multiple departments working in multiple areas. As you mentioned, it's clearly a cardiac process, but probably not a cardiac primary. And so you're looking for what's causing this hypereosinophilia and bring in the hematology group. And I know from my own practice, it can be hard when you've got a lot of cooks in the kitchen, but the teamwork that you all have provided here has been really tremendous.
Thank you, Rick. To answer Emily's question, it is really important to determine the cause of hypereosinophilic syndrome, which can be primary. That means it's resulted from a hematologic neoplasm, or it can be secondary. It can also be familial or idiopathic. So regarding the workup as a medical doctors, we always start with a thorough history and a physical examination, including skin exam and a palpation of the spleen. Reviewing any family history of hypereosinophilia or signs or symptoms of immune deficiency and a secondary cause can provide some clue for further investigation. Likewise, we usually start with non-invasive and cost-effective lab tests, including DBC with a differential blood smear, comprehensive metabolic panel with uric acid, LDH, liver function test, serum tryptase, and inflammatory markers like ESR and CRP. For hematology-specific tests, we send quantitative serum immunoglobulin, eosinophilia, fish panel, and flow cytometry from the peripheral blood. Once the initial test provide some clue on the etiology, we can proceed with more specific tests to further investigate the underlying cause. From the hematologic standpoint, usually an aberrant CBC differential or an abnormal smear such as dysplasia, monocytosis, or circulating blood sac, or clonal explantation of lymphocytes on the flow cytometry leads us to suspect underlying hematologic condition. So in those cases, we would proceed with a further investigation with a more invasive or expensive tests, such as bone marrow aspirate and biopsy or next generation sequencing. Emily, could you please provide us with the results of our patient's initial hypereosinophilia syndrome workup?
For an autoimmune workup, we sent an ANCA, ANA, cardiolipid IgG, beta-2 glycoprotein 1, myeloperoxidase, proteinase IgG, which were all negative. From an infectious aspect, we checked a hepatitis C core antigen, hepatitis C antibody, HIV, and strongyloides IgG, which were negative. And our hematology workup included a tryptase, which was normal at 10.4. CT chest, abdomen, pelvis was significant for splenomegaly. Bone marrow biopsy was not performed. Eosinophilia FISH evaluation showed an abnormal result with PDGFRA alpha rearrangement. How do you manage this patient from a hematological standpoint?
So this patient has primary hypereosinophilic syndrome, which is caused by a hematologic condition belonging to a group of disorder known as myeloid lymphoid neoplasms with eosinophilia and a tyrosine kinase gene fusion. In this case, the tyrosine kinase gene affected is PDGFR alpha. It is important to identify this translocation as it is responsive to tyrosine kinase inhibitors like imatinib. This patient was put on a high dose of imatinib, 400 mg daily, at our Malignant Heme Hematology Clinic. The treatment was successful and he achieved a complete hematological response, meaning his cell counts remain normal. Later, his repeat PDGFR alpha rearrangement came back negative. With the negative test, he entered a deeper remission called cytogenetic complete response. So the next step, we plan to continue lowering the dose of imatinib. Patients with hypereosinophilic syndrome with PDGFR alpha rearrangement usually have excellent response with low-dose imatinib. So the dose of imatinib can be as low as 100 mg once a week.
Thanks, Bei, for walking us through the diagnosis and management of hypereosinophilic syndrome. So the final diagnosis of our patient is primary hypereosinophilic syndrome with eosinophilic myocarditis.
And so thank you all again so much for this discussion. What an incredible final diagnosis. What an incredible discussion. Again, multidisciplinary teamwork. We went for a hike here in West Virginia today, and I didn't expect that we were going to be talking about tyrosine kinases and rearrangements, but this is, oh my gosh, am I glad that we did and glad to have learned from you all about it. Would you mind taking us through some of your kind of takeaways and reflections on this really amazing case?
Absolutely. Thank you, Rick, for having us here, and I'm glad that we're able to share our case with all the cardio nerds. Our patient who initially presented with chest pain was treated as NSTEMI, although no culprit lesion was identified on the initial angiogram. In the hindsight, that initial presentation of chest pain was likely the manifestation of acute stage of eosinophilic myocarditis. The absolute eosinophil count was 3,600 at that time, which was overlooked. Cardiac MRI should be obtained in all patients with MINOCA without any obvious underlying causes. And also of note, the classic echocardiographic finding of obliteration of apex with ventricular thrombus is highly suggestive of eosinophilic myocarditis. Cardiac MRI in our case confirmed the diagnosis with evidence of subendocardial fibrosis and biventricular thrombus with apical obliteration. And also it shed light on the patient was entering from second stage of thrombus formation to the third stage of fibrotic stage. And patient received a course of corticosteroids for his eosinophilic myocarditis, which is the recommended therapy for patients with such conditions. It's associated with lower mortality. For his apical thrombus, the patient received anticoagulation with warfarin. And after establishing the formal diagnosis of hypereosinophilic syndrome, we need to look for underlying causes for hypereosinophilia. The workup of the hypereosinophilic syndrome is broad, often requires a multidisciplinary approach. It can involve infectious disease, rheumatology, hematology, or allergy department. Our patient has primary hypereosinophilia syndrome with the PDGFRA rearrangement. It is secondary to myeloproliferative disorder with tyrosine kinase gene fusion. With the tyrosine kinase gene fusion, imatinib is the drug of choice. There are numerous case reports about full recovery of eosinophilic myocarditis after treatment, including resolution of thrombus and recovery from cardiomyopathy. So we all should be vigilant of this disease. Hopefully, patients can be more timely diagnosed and treated.
Couldn't agree more. What an amazing case. And as you mentioned, this isn't something we're going to see every day, but it is something that I personally will now keep on my differential. As you mentioned, biventricular thrombus is relatively uncommon. And one of the things we should have on our differential diagnosis, and that I'll have from now on, is hypereosinophilic syndrome. So I can't thank you enough for your time today, for all the learning. What a hike we went on and what a learning experience.
Thank you, Rick, and thank you, CardioNerds, for having us here. And I really enjoy listening to CardioNerds, especially during my drive and usual daily commute to hospital. It's just so much learning and so much positive energy coming from you all.
Guys, that was absolutely terrific. Thank you so much for being here. And we can't wait for you to hear yourself on your commute. Just drive safely, of course.
And next, I'd like to introduce Dr. Christopher Bianco. He's our cardiac expert at West Virginia University Heart and Vascular Institute. He obtained his training at Cleveland Clinic for Internal Medicine, and he entered East Carolina University for his general cardiology fellowship training. After that, he went to Case Western Reserve University for his heart failure training. Dr. Bianco has been a great friend to me, also a great mentor. Not only discuss cardiac diseases, he also plays table tennis with us when he has some downtime. I'm trying to catch up with my mentor and also enjoy our time together.
Hello, I'm Chris Bianco, and I'm a heart failure and transplant cardiologist here at the West Virginia University Heart and Vascular Institute. I'm going to start off by making some general comments related to eosinophilic myocarditis and Loeffler's endocarditis, then move on to comments related to our case and general diagnostic approaches to myocarditis, then finish up with the management of Loeffler's. So as for general comments, unfortunately, the disease spectrum from eosinophilic myocarditis to Loeffler's endocarditis is poorly studied and largely based on case series and reviews. What we do know is that cardiac involvement is present about half of those found to have hypereosinophilic syndrome. Eosinophilic myocarditis is still certainly possible in the absence of peripheral eosinophilia, and we know that from the largest systematic review to date, which showed that peripheral eosinophilia is only present in about 3/4 of those who are found to eventually have eosinophilic myocarditis. Eosinophilic myocarditis has been reported predominantly in young, middle-aged males in temperate regions. That said, unfortunately, this is probably a very underreported disease, and certainly a lot is yet to be known of this disease state and optimal diagnostic strategies and treatment strategies. This entity can have a very nonspecific or heterogeneous type of presentation that probably depends upon the duration the eosinophilia has been present or the cardiac stage at presentation. This can certainly range from largely asymptomatic patients from a cardiac perspective that may have been found to have another component of the hypereosinophilic syndrome that led to downstream cardiac testing, versus those who may present with a more significant acute myocarditis type of presentation, or those that present later on in the disease state with congestive type of symptoms more related to the potential restrictive cardiomyopathy that can ensue. Eosinophilic myocarditis to Loeffler's endocarditis, that spectrum has typically been described to progress through 3 basic stages. That first stage is a necrotic phase that's marked by myocyte injury. Imaging at this stage may be much less impressive, but as that progresses, then we get into a thrombotic phase. This is the phase in which these characteristic intracardiac thrombi are often present. Patients may present at this stage with thromboembolic events. I'd say one of the pearls to the type of thrombus that we see here, at least early on, these apical thrombi are found in areas that are of normal wall motion as opposed to the apical thrombus that we typically see in patients who are in the post-MI period, for instance, with underlying hypokinetic to akinetic segments. Certainly with continued damage to the myocardium, wall motion abnormalities may ensue. but at least early on, these thrombi tend to be in regions with relatively normal wall motion. These thrombi can be very large and impressive, and eventually oftentimes take on this characteristic look later in the disease course that's really pathognomonic for Loeffler's. The third phase has been described as the fibrotic phase. This is a phase in which the thrombus and granulation tissue in the second phase organizes and transforms into a fibrotic endomyocardial layer, leading to a restrictive cardiomyopathy. In my own practice, and speaking more generally here, in my own practice, I'm pretty aggressive with upfront endomyocardial biopsy in many cases of myocarditis. And we here at WVU not infrequently find patients with eosinophilic myocarditis that present with a seemingly run-of-the-mill myocarditis type of presentation. And this leads me to believe that we probably underestimate the occurrence of eosinophilic myocarditis by a predominantly non-invasive type of diagnostic strategy employed in most of the country. In my experience, this type of seemingly run-of-the-mill myocarditis that presents and then is found to have eosinophilic myocarditis is often related to exposures to certain medications or recreational drugs that, when held, resolves. So this being slightly different than once we get into the type of remodeling that we see with Loeffler's, but at least this type of eosinophilic myocarditis, I typically will give steroids, but I think that withdrawing the offending agent that drives the eosinophilic production is the key therapeutic move. So the concept of Loeffler's, and I'll preface this by saying this is largely unproven and more theoretical, is that with continued eosinophilic-induced damage, the process evolves into the then thrombotic and fibrotic stages. So Loeffler's, once it reaches the mid to later phases, typically has very pathognomonic type of imaging findings. However, I will say that diagnostic mimics to this entity can include apical HCM, as well as methamphetamine-induced cardiomyopathy. Unfortunately, I see a lot of methamphetamine-induced cardiomyopathy. Typically, this is a dilated biventricular phenotype that's very often associated with impressive biventricular thrombi health. However, I will say that sometimes we find patients that are probably earlier in the stages of meth-induced cardiomyopathy that may not be significantly dilated and may present with a myocarditis syndrome and these very impressive intracardiac thrombi that may mimic Loeffler's. And a good history and drug screen certainly clinches the diagnosis in most of those cases. Apical HCM can be slightly more challenging, and multimodal imaging is also obviously very helpful in these cases. A clinical pearl that I've encountered is that the ECG of Loeffler's can at times mimic the ECG of apical HCM, but the ECG of Loeffler's tends to be dynamic and change during the course of treatment. That said, at presentation, if you have no previous ECG, you really don't have that luxury, and they can have a very similar appearance, and this can cause confusion. I don't know the true data behind ECGs with an apical HCM pattern in those who have Loeffler's, nor do I think anybody really knows that, but in my own practice, I can attest to at least a few cases in which the patients actually had these precordial T-wave inversions, similar to the Yamaguchi's type of pattern, that did indeed have Loeffler's. I will say that, those patients that I've taken care of have this dynamic and improvement in those T-wave changes as they go through treatment, which would not be expected in one with HCM. So moving on to ARC-H and the general overall approach. As far as the overall diagnostic approach, I think that keeping a broad differential diagnosis, including myocarditis, is always important in the presentation of any chest type of syndrome. A good H&P is always important, particularly when considering myocarditis diagnosis. So a history that addresses new medications, allergic, autoimmune, connective tissue disorders, oncologic conditions, medications, or related symptoms to point towards any of those conditions is very important. Also, a travel and exposure history is important, particularly if we're evaluating for eosinophilia. Questions related to potential parasitic infections can be helpful. The standard comprehensive physical exam is important in all of our patients, Although I'll say as cardiologists, we tend to focus primarily on the cardiac exam, but we really need to also consider extra cardiac clues, including the skin examination, screen for palpable lymphadenopathy, etc., when we're considering conditions that may have a multi-organ involvement or syndromic features like we see in many of these hypereosinophilic syndromes. As for the initial labs, a CBC with differential with attention paid to the eosinophils, as well as, general cardiac biomarkers are important. Also consider labs directed towards other organ systems potentially impacted by what your differential diagnosis conditions may be are important. Sometimes labs directed at general myositis types of labs are important, as certain forms of myocarditis can be associated with skeletal myositis as well. If we have the luxury of a previous baseline ECG, finding dynamic ECG changes can be helpful to understand the likelihood of ischemia, pericarditis, myopericarditis, or potential signs of a new cardiomyopathy. Subsequent ECGs and telemetry with recurrent arrhythmias, particularly concomitant Brady and tachyarrhythmias, should raise concerns for myocarditis, some malignant forms such as giant cell myocarditis, but at the same time can certainly be seen in other forms of myocarditis. Concerning the troponin, as we all know, myocyte necrosis does not automatically equate to an obstructive epicardial coronary event, and if a smoking gun epicardial lesion is not found, that myocyte necrosis needs an adequate explanation and requires a sufficient workup. Echocardiography is typically the first imaging test, at least, and can be extremely helpful in the initial differential diagnosis. Although I will say early myocarditis may have very unimpressive echo findings. If echo and subsequent coronary angiogram, be it invasive or via coronary CT, are not indicative of a coronary event, further testing to explain the myocyte necrosis certainly needs to be considered. Ad hoc intravascular imaging and or physiologic testing in the case of invasive catheterization should certainly be considered on a case-by-case basis if an obstructive epicardial lesion is not identified. If a definitive diagnosis is not made by this point, depending on the index of suspicion for either microvascular disease or myocarditis, we really need to, evaluate any myocyte necrosis further with either microvascular testing or cardiac MRI, again, depending upon that index of suspicion of which is more likely to be the culprit for the myocyte necrosis. Highly characteristic forms of myocarditis, like Loeffler's, may be diagnosed non-invasively. Likewise, in patients with a known viral illness that then have subsequent MRI findings of myocarditis, that's probably suggestive of viral myocarditis, typically of a lymphocytic nature, and if uncomplicated, generally do not require endomyocardial biopsy. However, I'll say, if discordant findings are present or a complicated course ensues, I believe that endomyocardial biopsy should be strongly considered. That said, with the caveat that certain forms of myocarditis can be particularly difficult to diagnose via endomyocardial biopsy due to the potential for false negative findings related to sampling error, etc. So, thankfully, Loeffler's often has these pretty characteristic imaging findings that, in association with peripheral eosinophilia and the appropriate clinical context, the diagnosis can typically be made non-invasively. Loeffler's is an entity that requires multi-specialty involvement, certainly, to ascertain the underlying etiology of the eosinophilia prior to arriving at an eosinophilic syndrome diagnosis, or in those cases where there may not be peripheral eosinophilia, yet you find these clinical and imaging findings characteristic of Loeffler's. So certainly eosinophilic leukemias or other oncologic causes, as well as allergic diseases, sarcoidosis, connective tissue disorders, parasitic infections, they all need to be reasonably excluded. Furthermore, genetic evaluation for certain genes associated with hypereosinophilia should be considered. Certainly, if an underlying condition is identified through that workup, treatment of that condition is paramount to arrest the myocardial process that is happening. That said, in both secondary and primary cases, there have been a number of different approaches to addressing the cardiac component utilizing immunosuppressive medications and anticoagulation have been pursued. Typically, moderate to high-dose steroid tapering regimens with or without adjunct immunosuppressives are utilized, along with anticoagulation and continued surveillance imaging throughout treatment. This was an excellent case. I want to, give a shout out to our excellent trainees, our fellow Li Pang and IM resident Emily Hendricks for presenting this excellent case. I also want to acknowledge Dr. Bala, our cardiology fellowship PD, Dr. Sokos, our chief here at WVU. To all those listening, consider come training with us and working with us at WVU to see a vast array of pathology. And last but not least, I want to thank CardioNerds for featuring our case. Thank you and have a nice day.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Tina Reddy. I'm an intern in the CardioNerds Academy House Thomas and fourth-year medical student at Tulane University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.